I'm James. I'm going to be talking to you about paediatric head injuries, and it's a bit of a big subject, so I kind of jump around all over the place. But I'm hoping to cover a little bit about pathophysiology, a little bit of statistics, as you might have already seen, and cover a little bit of assessment and management, and then hopefully avoid any questions at the end. Let's get on with it. So, why do head injuries matter in paediatrics? Well, quite simply speaking, they're the most common cause of trauma in children. And this is a graph from the time data that was published about trauma in children between 2019 and 2020. And you'll see a few more of these graphs here. But as you can see, that the number of injuries from children with severe injuries that involve their heads massively outweighs any other body system. So they're really important and they're really common, and they're a source of anxiety for all of us who go out pre-hospital and see children. So some more statistics, just to make myself look a bit clever, like I've done some work. There's more boys and girls get affected by traumatic injuries overall, but especially head injuries in children. And there's a striking age distribution as well. It's the under ones and an increasing age during the teenage years as they indulge in more risk-taking behaviours and activities. Sadly, you're most likely to suffer injury in the first 4 months of life, and it's most likely to be non-accidental injury or suspected parental abuse. And head injuries are by far the most common type of injury. So how kids get head injuries, there's more data from time. It sort of shows us that road traffic collisions are the most common mechanism of injury, followed by small falls for us, so that's under 2 meters. But obviously, if you're a little kid, 2 meters can be quite a lot. And then bigger falls for everyone, which is over 2 meters. And then the sad thing of suspected parental abuse, which only gets counted up to 2 years old. So 3 years and above, it goes down as assault rather than suspected parental abuse. And so if you add that bit on to the figures, if you assume that they're all parental non-accidental injuries, then you can see that there's quite a lot of assaults or parental injuries. There we go. So yeah, this is a different version of the same graph, basically. And as you can see from here, the most likely mechanism of injury varies with age, coincides with the children's development and the environments that they're in. I am labelling this point, and you'll see why in a minute. But suspected parental abuse is so common under the twos, especially under 4 months, as we saw before, because this is when children are the most frustrating for their parents, and the parents have the least experience of how to deal with that, especially new parents. And kids are at this age fully dependent on their caregivers, and all they can do to communicate their needs is cry. And they cry because they're hungry, they're thirsty, they're tired, they've got a dirty nappy, they don't like music, they don't like the TV program, they don't like the new face that's just walked into the room. Maybe they're too hot or they're too cold, or they want to cuddle, or they want someone to leave them alone, they want some attention, they want a different toy. Maybe they're just trying to communicate more than one of these things, but they only have one way of doing it. So one thing gets fixed, but there's something else that they don't like or do want at the same time. And then as they get older, kids become more mobile and they fall over, hitting their heads on the furniture or the steps or whatever it is they didn't notice because they were too concentrating too hard on putting one foot in front of the other. And then they start to notice the outside world and they want to explore. But the problem is they're inside a building and they just don't understand that open windows don't keep them as safe as closed windows, because they can see the outside world just as well through both. And then with the road traffic collisions, we see a change there as well in age distribution, because car seats go from rear facing, which are much safer for head injuries, to forward facing, and then they become glorified cushions so that the seat belts fit a bit better, and then they move from the back to the front of the car, which is a hard dashboard instead of a softer seat, and then they start getting lifts with their mates or older siblings, or who have just learned to drive, and then their mates who have just learned to drive, and then they just learn to drive, and some even start riding quad bikes for recreation or even motorbikes, and that can happen from quite an early age as well. And then they get mobile phones, and suddenly TikTok or YouTube becomes more important than the Green Cross code. And they're not even watching the Kid Confident channel, which you should all totally subscribe to, by the way, because there's some big stuff coming through on YouTube very soon. And so you can see how the mechanism of injury and age become related, and why paediatricians always go on about the history. Sometimes it's looking for inconsistencies in the story itself and in the reported mechanism related to the child's stage of development to determine if non-accidental injury is a factor. But why should you and me, why should I care as hospital clinicians about this? Because we just see what we treat what we see, rather, don't we? Right? Well, we care because we need to recognize patterns of injuries, and we notice as kids get older that their body proportions change quite dramatically from newborns through to adulthood. So when children are born, their head takes up 25% of their total body proportion, and then by the time they're teenagers, that 25% goes down to below the shoulders. So children have big heads in proportion to their body. The smaller the child, the bigger the head, and they also have underdeveloped neck and shoulder muscles the younger they are, which means that they can't really control their head movements as well as when they're subjected to a force. So they basically have some big floppy lollipop on top of their body which wobbles around and hits things more easily. Under two, they're most vulnerable to head injuries because of that lollipop thing. And this also, as we all know, has implications for our airway management with their big heads and their occipits and squishy cartilaginous bits where there should be bone, which the fontanelles. And under 12, they're still more vulnerable to C-spine and head injuries because they've got weak shoulder and neck muscles, which haven't quite got developed. And then when they get over 12, they're just getting bigger and stronger, and their necks and shoulders are developing, and they're less high risk for getting head and C-spine injuries. So I talked about the squishy bits, the fontanelles, and this is just a little reminder of your anatomy, because the posterior fontanelle closes by around 2 months, sometimes closed at birth, but the anterior fontanelle is open until 12 to 24 months old. Some sources say up to 5 years, but it's, general rule, by the age they're two, they're starting to harden up. But then these cranial sutures, the little gaps between the bones in your skull, stay flexible until almost early adulthood when growth stops, and they may not fully fuse actually until people are 30 plus. And that might be protective after injury, but it still makes brain injury more likely to happen too. And less protection around the brain and the meninges, more compliant skull, which may be protected for raised ICP to a point, as I've just said, but because it can stretch, but it changes how we detect raised ICP as signs. Might not be as apparent until the intracranial volume is maximized, which is why bulging fontanelles are a thing in the little ones. And they should be continuous with the skull bones, and we know that looking for sunken fontanelles are a sign of dehydration, which may be due to bleeding in the context of trauma, and then bulging or raised fontanelles are a sign of increased intracranial contents, which we will look at in a minute. And this may precede other signs of raised intracranial pressure, which we traditionally detect in adults who can't accommodate that poly. And then this leads on to the last reasons why kids are more prone to head injuries. They've got more compliant brains and intracranial tissues like the meninges, which leads to a higher risk of bleeding and diffuse injuries as well. So subdural bleeds are probably the most common intracranial findings in children. Definitely the most common ones in those that suffer abuse. And so we should probably actually have a higher index of suspicion when we consider all these things for injuries involving head and C-spine following relatively low energy transfers compared to adults. And we should definitely appreciate that the pediatric brain is less tolerant of hypoxia, hypotension, hypoglycemia, which can all lead to secondary brain injury and worsen outcomes as well. So that's that. Most of the injuries that children get, as you can see from this picture, are the same things as adults get. It's just spotting them can be different at times, but there's one specific thing which I might have already alluded to, which is definitely in the realm of pediatrics only, and that is shaken baby syndrome. I don't think I'm going to be in danger of suffering from shaken baby syndrome myself. and I said about the suspected parental abuse in the under twos, didn't I? Because caring for a baby can be very rewarding, loving, and exciting, but it can also be really frustrating at times. And shaken baby syndrome is a thing and is defined as a severe form of child abuse, actually, that results from parents or caregivers violently shaking a baby or a small child. It's the most common cause for inflicted brain injury in the first 2 years of life, and it's also, sadly, the leading cause of death and the most common cause of permanent damage and long-term disability in children and infants who have been physically abused. Because the head is relatively large and the neck muscles are underdeveloped, like we said, and provide very little support, the shaking motion causes a child's brain to repeatedly hit the front and the back of the skull, leading to potentially fatal consequences. Most of the time, there's no like criminal history or drugs or alcohol history of the parents. It's just regular parents losing their control out of frustration, which actually makes it a sadder thing, doesn't it? Um, those rapid acceleration deceleration forces can cause the brain to strike the inner surface of the skull, resulting in bruising, swelling, and diffuse axonal damage. Retinal hemorrhages, which can only really be detected by slit lamp examination and not really pre-hospitally, and intracranial hematomas, mostly subdural, like we said, but you also get some subarachnoid hemorrhages, are the most common injuries sustained. But because of the flexible nature of a baby's skull, it can be a bit trickier to detect, and I might have just skipped through that without going through the slides. So there's some image showing the forces exerted on the brain and how that causes the damage, and a list there of some of those injuries that I rattled through. So it can be difficult to take, but we do have a few things that we can look out for. And they're not actually specific to just children or babies. There are basically signs of intracranial pathology in anyone. And this is them. These are the things you look for, all the signs that you know about already for head injuries in adults, really. And these include things like lethargy, lack of movement, inability to stay awake, vomiting, inability to cry is more specific to children, because once they get shaken, sometimes they lose that bit of brain control that tells them that they should be crying because they're sad, and they don't even know how to cry anymore. So that's why they don't cry. Or they might cry inconsolably, so it might be complete other end of the spectrum. So whatever anyone does, they just keep crying with and so with a history of shaking or being put down forcibly, this type of injury should be a consideration. And as I said, these aren't just signs of being shaken, they're signs of intracranial pathology or injury that can be looked in for any scenario where you might suspect head injury. So that's shaken baby syndrome. And then the other thing, just for those of you who are involved in events cover for sporting events, or even if you're not, you may be called to see a child who's been sat out for possible concussion. It's just to mention concussion, really, because more kids do sports and contact sports than adults do. And concussion is a thing, and it's getting a lot of publicity because of some incidents that have happened in grassroots sports over the last couple of years. So concussion is defined as temporary injury to the brain caused by a blow or a jolt to the head or by a knock to the body that results in the head moving rapidly. And it affects the way that the brain functions and can cause a range of symptoms, including headache, dizziness, and confusion. But most concussions don't involve a loss of consciousness. And one of the definitions actually says that if there is a loss of consciousness, it has to be less than 5 seconds. The important thing about concussion is recognizing it actually and monitoring the child afterwards for any deterioration, which could be a sign of a more severe injury, and he's investigating for the reasons that we mentioned earlier. And if you are covering an event, then it's important to recognize the potential for concussion injuries and understand that this can lead to long-term harm if ignored. So if in doubt, sit them out. That's the strap line, and that is the title of the guidelines that have been produced for people who cover sports events or grassroots sports events anyway. And it's a really useful resource actually. So I've put a link to the guidance on the Kid Confident page that this QR code links to, and the address for it is just there on the screen now as well. So if you do cover sports events or you're interested in concussion, head injuries and the management, check that out. it could be a whole webinar in itself, so I'm not going to say any more about that. But what I'm going to say is about assessment. It basically assessment of head injuries in children is the same as assessment of head injuries in adults. But we've got a few bonuses, we've got a few extra things that we can use to make it easier for us. And the first one of those things is my favorite assessment tool ever, and that is the Paediatric Assessment Triangle. This is just enables you to make a quick, slick assessment of the child as you approach them, telling you if they're sick or not sick, and it's beautiful because it allows you to make an assessment without using any equipment and without even touching the kid. And it's not a diagnostic tool, and that's important to understand, but it allows you to make a quick assessment of how unwell the child is and where to focus your attention. And this in turn helps guide your decision making about the urgency that the child needs to have treatment or any interventions. And this is really good to use in combination with your usual trauma approach. And if you want to learn more about this, then check out our previous webinar available on YouTube about pediatric assessment. So there we go. With trauma assess, your normal trauma assessment is the same as in adults. Your CABCDE approach. Your primary survey is a primary survey for life-threatening injuries, and in trauma, it's the same things that kill children and in adults. And if they've got a head injury, it's the same things that give them worse outcomes. And head injuries actually are the highest cause of death from trauma in children. And the things that you most specifically need to look for are airway obstruction, hypoxia, bleeding leading to hypotension, and then a few other little bits which we'll go into now. But that's basically C, A, B, and C done. And so it's exactly the same as what you do for any other trauma patient, and it's the normal structured approach that you're used to. One thing that we do always talk about in trauma is D for glucose. I mean, don't ever forget glucose, and everyone goes, yeah, it's trauma, who cares? But in children, it is really actually more important than it is in adults. It can be quite common in critically ill children, even non-diabetics, and the younger the child, the more susceptible they are to hypoglycemia as a result of illness or injury. In trauma with head injuries, and head injuries being the biggest cause of hospital admissions, doing a BM is regularly overlooked because, and this is important because the brain does almost exclusively use glucose and oxygen to metabolize and create energy to work. So when the body's in a stress state, like when you've got a head injury, glucose and oxygen utilization goes through the roof, and this can be seen through brain activity, and we can measure that really easily. Actually, it's one of those first things in the pediatric assessment triangle because central nervous system activity is responsible for your tone interactivity and irritability, and your speech, which is that all of the things, the appearance component of the pediatric assessment triangle. But if you remember that kids have tiny livers, they're not very good at storing glycogen, so they haven't got any reserves really, as much reserves anyway, to convert to glucose to metabolize when they're in stress states. The other way, I mean, move on from the pediatric assessment triangle, and we're doing our CABCDE approach, is the pediatric GCS, because that's a little bit more refined way of assessing their brain activity, and it might also be a clue that they are suffering with their glucose stores because they're in a stress state, and remind us to check them out. Sometimes you hear that doing a GCS in a young kid is difficult because they're non-verbal, so you can't score them on the verbal part of the GCS score. And there are some approved adaptations to the adult GCS for use in children and non-verbal patients, actually, including autistic patients and those with learning difficulties and babies. And this little resource card or little aid memoir with that adaptation on is available on the Kid Confident website as well as a free download. Everything's free on there, so feel free to download things and print them and distribute them and share them. And if you're going to comment badly about them, do it to me, because I'll learn from that. But yeah, in cases involving potential brain injury, it's a really useful prognostic tool, helps guide management, and in medical cases, it also gives you a clue to the physiological effect of illness. And it's a tool we're all used to using in adults, so it's not just brain activity from hypoglycemia, it's to do with the head trauma as well. and a head injured patient, and is a core assessment for all of these patients with head injuries, because it helps us communicate the severity of the injury without going into loads of detail, and focuses the receiving team in hospital to mobilise the correct response for when you arrive, which is a good thing to do. And that's enough whittling on about assessment, because we've done a webinar on that, and you all know how to do your ABC approach. But we'll talk a little bit about management specific to head injuries and the science behind it as well, because that kind of, if you understand the science, you kind of helps you understand what's going on. And I don't think I'm going to tell anyone anything that they don't already know, but we're going to recap it anyway. It's all about intracranial pressure, isn't it? And I said they can be harder to spot the signs because of more compliant skulls. But even with this extra compliance, ICP does become an issue, and we do start to notice physiological signs of injury. And the Monroe-Kelly doctrine explains why intracranial pressure increases, because it says that the skull is a box with a fixed volume, and that, what we was talking about, fontanelles and the sutures, is why that might delay some of the signs in children, but still the extra contents can't escape to maintain the fixed volume. So as the contents of the skull increase from bleeding or brain tissue swelling, so does the pressure inside the skull. And even in the youngest children, this becomes true. So some CSF can escape into the spinal cord, but not too much. And some of the blood can escape into the venous circulation, which is one reason why we might see engorged veins in the head injury patients. But this increase in intracranial pressure means that high pressure is needed to perfuse the brain. And that's why we start seeing signs like reductions in GCS and interactivity in patients with head injuries. And this equation describes that relationship, doesn't it? And we know that the brain can auto-regulate blood flow between a mean arterial pressure, or MAP, of 50 to 150 usually, to maintain a perfusion pressure of between 60 and 100 millimeters of mercury, which is the what we know from other studies and other organs, what you need to make them work. But when ICP rises, this becomes harder, and in the context of trauma, where there may be other injuries outside the head causing bleeding, this might be even harder because your MAP becomes compromised. So that means that you've got a lower driving pressure to achieve your perfusion pressure, and you've got a higher intracranial pressure, which is opposing that perfusion. So in head injuries, because I can't measure what somebody's ICP is outside of a neuro-intensive care, I always assume that it's 20 in head injured patients. The normal value would be like less than 10. There are ways to estimate it with advanced ultrasound, but it's complete faff, waste time, and doesn't give you an absolute value. There's too much operator error, or in variability, rather, I should say. So it doesn't really tell us anything that we don't already know. If they've bashed their head and they're a bit drowsy and they're not quite right, their GCS is low, they probably got raised ICP, and sticking an ultrasound on their eye to measure their optic disc ain't really going to tell you any more than that. So this is why we need to give oxygen to all of our brain injured patients, especially kids, to raise the amount of oxygen in the blood to try and maintain oxygen delivery to the brain when blood flow is reduced. So more oxygen in the blood, so the smaller amount of blood getting to the brain has more oxygen in it, which means it can deliver hopefully the same amount that it needs to survive. And that's also why we need to give fluids to maintain an adequate blood pressure, or MAP, to overcome the rising intracranial pressure and produce that adequate cerebral perfusion. I hate maths. And all of this doesn't do anything about the primary brain injury, because that's already happened before you get there, but it does significantly help secondary brain injury. So how do we manage intracranial pressure apart from giving them loads of oxygen and some fluids when they're hypotensive? I mean, it's these simple things that we do in adults as well. We position them differently, so we try and get them slightly head up. Approximately 30 degrees is what the books say, but we just achieve what we can, and that might be some rolled up blankets underneath a scoop on a trolley, because they still need to be securely fastened up in the back of an ambulance when you're taking them to hospital. And we do everything that we can to facilitate venous drainage, like not putting a collar, and we wouldn't put collars anyway now, do we? But we still hear sometimes that because it's a kid, they want to put a collar, people want to put a collar on, so never put a collar on, and especially not if you think they've got a head injury, even if they're completely obtunded, and you need to immobilize them. Blocks and tape is fine. If you do need to do any advanced airway management, you put a eye gel or even intubate them, then we'd advocate that you tape this in place to secure it rather than using ties or even the Thomas device, because that compresses the neck veins and reduces venous drainage and therefore increases the contents of the brain and increases intracranial pressure. Give oxygen, like I've said, target normal end tidal carbon dioxide. Too much or too little CO2 in your blood is bad for brain perfusion. We treat hypotension, we treat seizures because they use up oxygen, glucose, and create acidosis as well. And we treat pain and maintain a normal temperature. All the things that you would do in an adult as standard care. And then there's a couple of smart comments that I sometimes get. So I just want to bust these myths now. Myth number one is that over-oxygenation causes brain injury. This might get me on a rant. So Anna, if I go on for more than half an hour about this one point, can you just like put the elevator music on or something? Because some clever people often tell me about the risk of excitotoxic injury from hyperoxygenation, and there is, to be fair, some evidence for this from patients that have been in intensive care for a million years. But the point that gets missed is that hypoxia is an independent risk factor for brain death and is a much bigger risk factor than the potential risk of free radical damage, which occurs over time on neuro-intensive care units. So, in fact, actually, hypoxia is 100% guaranteed to cause some sort of brain damage or even death if it's not treated. So, please give oxygen and worry about all the clever free radical excitotoxic mumbo jumbo to people in neuro-intensive care who get paid more to worry about that. And then the other myth that I want to bust is it is less of a rant really, but too much fluid causes cerebral edema, which worsens intracranial pressure. Because you get cerebral edema, you're increasing the amount of brain tissue that's taking up space in the skull. And this is true to but you do have to give quite a bit of fluid to cause cerebral edema. And if you've got a patient who's fluid deplete, then it's not really as much of an issue, because we've just seen how intracranial injury can reduce blood flow and therefore oxygen delivery and reduce perfusion. So maximizing their blood volume as well as their oxygen is really important. And it's quite a simple principle, isn't it, really? We know from lots of studies that in the acute phase, hypotension kills and leads to worse outcomes neurologically and mortality-wise as well. And we just saw that equation, why that is too, in brain injured patients. ICP is rising and cerebral perfusion can be reduced. And this is why the Cushing's response happens normally, isn't it? So it's a physiological survival mechanism which attempts to maintain your brain perfusion by increasing your blood pressure, so to overcome that raised ICP. So we really should be giving fluids for hypotension in these patients with head injuries, and there's so many studies that show hypotension in head injuries leads to worse outcomes. So don't believe the hype. Give fluids and give oxygen, and check the glucose. Always check the glucose as well. This is a summary of what I think we should be doing. It's completely stolen from one of our posters, which is available through that QR code, funnily enough, because our aim when we're out at work and seeing all patients of all sizes is to save and preserve life, isn't it? And when we're trying to do this in resuscitation, we think of the 4 H's and the 4 T's, and the same 4 H's and T's are also what we need to be thinking of with head injuries, which makes it easy because we all know the H's and T's. So give oxygen, aim for a normal end tidal carbon dioxide. If we have to assist with ventilation, too much causes vasodilation, so increase the amount of blood in your brain and therefore increase your ICP, and too little does the opposite, so it causes vasoconstriction and that reduces blood flow and oxygen delivery. So both things are bad. Aim for perfect. Um, Give fluids for hypotension, and in adults, we would target a systolic blood pressure of 90 as a minimum in head injuries. And in children, that probably isn't a bad figure either, but a rough guide to the absolute minimum systolic blood pressure we can tolerate in kids is 70 plus twice their age in years. Um, and there's a lot of info in those last few slides. So if you want to see the full posters, which they came from, this QR code will take you to them, and the other trauma series posters as well. So you can have a little look at that, about all the details of ICP, and management of head injuries as well. One thing just to mention, I did sort of kind of mention it, is seizure management, because seizures use oxygen and glucose, and they're a feature of head injuries towards the more severe end of the spectrum, and they're important to manage, as seizures use up your oxygen. Glucose are also producing lactic acid from muscle activity, contributing to acidosis, which in the context of trauma is really bad because it contributes to coagulopathy, and then you get hypothermia, and you've got that whole triad of death thing going on. The heat, though, generated by seizures may also have an impact on brain function and damage. So we need to manage these as per the guidance in JRCALC and within our ambulance trust. And I'm not going too much into that because I'm aware that some trusts have different drugs available to them. But all the information you need is on the lovely JRCALC Plus app. And we might cover that in another webinar soon anyway. So classification of head injuries in children. I've finished ranting. So what kind of head injuries do kids get? It's the same as adults, isn't it? They get the subdural, extradural, and subarachnoid hematomas. They get diffuse axonal injuries, retinal hemorrhages, because the eye is really just a bit of brain on a stalk, isn't it? And then spinal cord damage, because spinal cord is just a bit of brain that is a stalk. But they also get the scalp injuries, concussions, skull fractures, all the things that you know about already. And the reason might be different, but the injury itself is the same, and so is the classification. And so we have this, don't we? They're classified as mild, moderate, and severe. And this is just a rough guide which will pull together to help you classify injury severity using the information on JRCALC and in NICE. And it just shows you that as things get worse, then it's classified as being more severe injury. And this helps us categorize decide our conveyance decisions as well, doesn't it? And NICE and JRCALC gives us loads of information and guidance about that. But actually, there currently is no pre-hospital tool to support decision making, apart from just the guidelines that are there, and on JRCALC especially is probably the most useful thing for a decision tool that just tells you this whole list of bad things that mean kids have to go to hospital or adults have to go to hospital. But there is a group who are researching this, and they have published some excellent work in the past 2 years. So I expect there will be a specific tool in the future which sort of might let you leave more kids at home with some safety netting advice and monitoring. Because the only decision tools really at the moment about whether somebody has got a severe head injury are based around the need for CT imaging, and that's not really a thing for us. And all children, but needless to say, all children with severe head injuries should probably go to a children's major trauma centre, especially traumatic head injuries. And there is a map available using the QR code, and they're often different to the adult MTC, so it is worth them you look at. And even if they don't have neuro on site, they will have fast links to neuro centres, and they will be well set up for that, because they recognise that the major type of injury that they see in trauma in kids is head injuries. The guidance from JRCALC specifically mentions non-accidental injury and clinician concern, and these are clinician concern is a really sensitive indicator. So if you are concerned, and even if you don't know why, just take the child to hospital, because you'll have something in you to do with your training and your clinical abilities that's telling you that something is not right, even if you can't put your finger on it. And I think that's really, really important. And I think it's underestimated, especially in pre-hospital world. So back yourself and back your suspicions. And if you're concerned, even if you don't know why, do a pre-alert and take them in. And the same actually applies to parental or caregiver concern, even if they've been reviewed by a clinician early in the day. If they've later called for an ambulance and you've turned up, then take them in, even if it is just for reassurance from someone with paediatrics written on their ID badge. And we speak about this 3 strikes rule in sepsis, and I think it probably applies to all presentations, doesn't it? Parental concern cannot be underestimated. They know their kids better than anyone else, and if they're worried and they think that they're not normal and they're concerned, and even if they've been reassured by one person or 2 people, and they're asking for more reassurance and review, then it's probably justified to take them in. I personally don't know any paediatricians who would be upset reviewing someone because of parental concern, and I think that's an important thing to reassure you guys, that you shouldn't be blasted for taking someone in because you're concerned or a parent is concerned as well. What about non-conveyance? The JRCALC and NICE tells you that if there's no concerning features that were on that list before, they've got normal behaviour for their age, they're not throwing up, and they've been alert the whole time, you're probably all right, aren't you? As long as you've got a reliable adult who's going to be able to supervise them for at least 24, 48 hours, and you provide some safety netting advice. Parents feel confident to be able to monitor and spot any signs, and they understand what the red flags are, then I think they're all good to stay at home. If you are going to do this, NICE does strongly advise that you have some shared decision making if you're not taking them to hospital. So your shared decision making is in the ambulance service is to probably talk to a senior clinician in control before committing to leaving them at the community where there is a history of head injury. And it's really important for your own protection and for good clinical care anyway, to document this conversation with who the senior clinician is, and that you've had this conversation before leaving them at home in the notes. And there's the safety netting advice, which needs to be left, and where we can get this from. They've got a very good website on NHS UK. They've got some information about head injuries and concussions for parents, giving them some advice of things to look out for, and what to do and what not to do. Because let's be honest, if they've called you to come and review them and they've got a lot of going on in their head, they're very worried. Taking in some information and remember all of it is going to be really tricky for them. So being able to signpost them to a resource like the NHS website can be really, really helpful. And it looks like, after I did all the effort of doing it, there's a little handout that I did that I was going to put on the slide that basically has a QR code to this website for the family, and it's got a little summary of the classification of head injuries in children, and when the red flags that mean that you should be transporting them immediately to hospital, and the things that you can leave them at home, and it's got a QR code to this link as well on the NHS website. So that's on that QR code that I was showing before, and I will show again. If you want to download that as well. It doesn't replace any guidelines, obviously, but it is made based on all the guidelines as well. So make sure you give them some safety netting advice rather than just telling them that was the point, sorry. Yeah, we used to have on the old paper PRFs, didn't we? We used to have all the head injury advice on the back, but you can't really your tough book or iPad now because you need that for the next job. And then remember this, I said about it before and I've labelled it again, and I talked about it more in the assessment webinar, but it is important because our safeguarding assessment does start the moment we pull up outside a paediatric job, even if we don't realise it. We start taking the information about the environment, the family, parents' ability to cope with the child and the child's development needs and how they're being met as well. It's not a snapshot assessment that you do intentionally, but it's a picture that you build up over the time that you're with the patient, and it helps us make decisions or judgments which may have a huge impact on the rest of the child's life, both medically and psychologically. So it's really important. It might even influence their trajectory in life. So it's really important for us to acknowledge this as an assessment tool and not just a bunch of stuff we noticed. And especially in the context of head injuries, looking at those statistics at the beginning of the talk, It's something that you must remember to do and document more as well when dealing with head injuries.